Ever notice someone dragging large black bags through the hospital lobby and wonder who they are? That, my friend, is a medical device rep. Welcome to Device Guys. Your hosts, Brent Lloyd and Jason Doliak, bring 50 years of combined medical sales experience to the table, sharing insights, stories, and a behind-the-scenes look at this fascinating world. Enjoy the conversations.
Hey everybody, I'm Brent. He's Jason. We're the Device Guys. Welcome to the podcast. Jason, how do you do?
I do quite well, buddy. How do you do?
I do good.
Good. You're looking great. You look this very fall.
You like that?
Yeah, it's nice.
Well, it is fall.
Well, I mean, the seasons change, you know.
Yeah,
Leaves are turning.
I just picked these this little quarter zip number up. I bought more than one. I find something I like, and I go with it.
You multiply it. That's a smart move.
I think I wore a black one when Don Dunn was our guest.
Oh, that's right.
I lightened it up a little bit today with the white.
Where's this come from?
Straight down.
Straight down.
Mm-hmm.
Oh, did you get that at Bonneville Pro Shop?
No. I got this on right from their website. Right from their website.
Okay. All right.
I got the one I wore with Don. I got it at a hotel, and I liked it so much. I looked at the model number, and I found the company Straight Down, and I bought two more.
I feel like it's a golf brand, isn't it?
It is a golf brand.
Yeah. I swear I've seen it. I thought I saw
they
that
have
one
everything.
at Bonnie, I think.
Did you really?
Yeah.
Bonneville Municipal.
Yeah. Well, we've talked about it.
Yeah.
Oh, speaking of which, man, how about my golf round this week I told you about?
Yeah, I think we really need to cover it. We need to talk about it. Can I get the background? I called you.
Yes.
See what you were doing, and it was like 3:00 in the afternoon, mm-hmm. and you were at a golf course.
I was sitting in the cart. I was sitting in the cart.
Yeah.
I had that morning. I said, "Hey, you free this afternoon? You want to go out and shoot 9 holes?" And I got a text from the guy. And I'm like, "He's in my contact list, you know," and nice enough guy. And he's invited me to play golf a couple of times. I'm like, I don't know this guy. I can't remember him. And so I'm talking to you. I'm like, hey, I'll come out here to play golf. I don't know what the story is.
You were waiting for this guy to show up.
Yep.
He invited you to play golf.
Correct.
You had no idea who he was.
No idea.
Other than you probably met him on a golf course and
that's
you
what I
saved
assumed.
his number in your phone.
I assumed, and I saved his number. The picture he had kind of attached to his contact wasn't close to his LinkedIn profile.
So you then kind of stalked him on the internet.
I stalked him a little bit, yep.
To see if there was a little jog.
Yes.
But there was no jog.
There was no jog. Well, because I mean his business, he's a corporate finance investor. And so I'm like, well, he doesn't want to talk to me.
Well, you didn't know that.
No, I found out.
You found out, but for all you know, he could have had a crush on you.
This could have been a blind date.
Yeah.
Absolutely. Could have been a blind date.
Yeah.
Listen, we're going to go out there. We're going to go beat it around, the old Fairmont golf course in Forestdale. Yeah. Fairmont's the park on the other side.
Yeah.
But Forestdale. So, yeah, I walked into that. Could have been, I'd have let him down gently, you know.
Well, I mean, you know.
Or maybe I wouldn't have. I don't know.
You would have to play it by ear, maybe. You know. Willing to try new things.
I'm open-minded. I mean, come on.
I mean, this is what I love about you, is this guy calls you and you're like, yeah, sure. You have no idea who he is. You don't remember him at all. But as it turns out, it was kind of a...
It was a group meet. It was a kind of a group, socializing, get corporate contacts.
Yeah, it was a sales thing.
It was a sales thing. He was doing a good job. I mean, he came out and he networked with everybody there. He had 2 tee times. I went ahead and jumped in and paid for my greens fees early.
Well, that's on you, bro.
I don't assume. I don't assume. But it was great. It was a nice little outing. 8 guys.
Now, are you investing with him now? Do you feel like, did you give him some money to?
I'm not a corporate finance guy, but I'm going to continue to talk to him, see if there's good connections there.
Well, that's what I love about you is you went in, you're like, okay, I'll meet this guy.
Let's go see.
Yeah.
It's like I tell the kids nowadays: say yes to opportunity. Don't shut things down. Say yes.
No, I think that's good. I think there's something else we need to cover because we did talk about your 50th birthday on a couple of pods ago.
I think so. Yeah.
It's now come and gone, and you did have a little party.
I did. Yeah. Thank you very much for setting up that venue. That was fantastic.
Yeah, I did help with the venue. I helped less with the venue than Heather did, but
Well, yeah, you married her, and she did the rest.
And she did the rest.
Right. It's clear.
But it was a nice event.
It was a great event.
And I got to meet. No, I met Michael before your brother.
You met Michael. You might have met Kenny. Probably not. Maybe, I don't know.
I've only seen pictures of Kenny, but Kenny, he was good. He was solid.
You like the outfit?
I liked the outfit. There were some good outfits. I think the highlight of my night was meeting Dr.
Doliak.
Dr. Phil.
I did see that he monopolized your time.
Yeah, he did. He got his claws in me, and I was right there. But part of it was I started this conversation about, implicating him in telling Rick Majerus how to play his son. And he totally disagreed with me. And I gotta be honest, it was a little awkward.
I love it because I'm pretty sure he is remembering that story incorrectly. I had to bring my brother in and figure out what exactly happened. But I mean, stories get retold. So,
well, Heather was giving me one of these under the table. Like,
you need to knock it off.
But I was already gone down the path. He said he was not that dad. He would never call Coach Majerus. I'm just saying.
Yeah.
But it was fun to meet him. I think we did talk about having him on the pod, but it was just a little too much for that weekend to get him in here.
It was too much for that weekend. That would be fun. It'd be fun to have this debate with him in person because it'd be good to kind of just hash it out.
It would be awesome.
Yeah.
And also, you did, speaking of your brother Michael, you did show me an Instagram today.
Oh, how'd you like that?
Shaq. And it would be fun to talk to Mike about that Instagram. You want to tell people about that one?
Oh, yeah. I mean, that one was sent to me by.
Or is YouTube?
I don't know.
I think it was YouTube.
Probably YouTube.
Yeah.
But yeah, it was just a conversation Shaq was having about the guys that posted up on him, and he's like, I even got beat by some of the sorry guys. It's like, yeah, you guys remember Michael Doliak? Guy went off for 25 on me. I couldn't stop him.
Couldn't stop him.
Slippery.
Mike owned Shaq.
Oh yeah, right.
He owned him.
Oh
really.
Yeah. Backed him up for a bunch of years in Miami.
Yeah. Right. Got a ring. Let's talk about our guest. As we can see, we have the clinician's tablecloth, the blue drape.
Yes, we do. And this one's an exciting one because this one is kind of the unsung heroes in the hospital that kind of are a part of every single procedure that happens.
I might even say sung.
A sung
hero,
Absolutely.
Not just unsung.
I mean, these are the guys that make it all possible by putting us all into a position where we can undergo these things without discomfort.
Well, the other thing I love about this guy is you and I both have a history with him.
We do.
And he's just one of my favorite people. He's a very interesting guy.
He's one of my favorite faces to see when I walk into the lab. And if we've got anesthesia in the room and it's Dr. Bergquist.
I like seeing Dr. Bergquist too. But I know it's going to be a long day if that's the case because he likes to chat it up.
He'll chat it up. Turnover time is
it might be a little impacted. Hey, but we need to give him a chance to defend himself. Let's bring him out here and we can have a conversation. Everybody, let's bring Dr. Barry Bergquist.
Welcome to the show.
To the podcast. Barry Bergquist, welcome.
Device guys.
To the podcast.
Yeah, here we go.
How do you do?
I do quite well. Thank you for having me on.
Oh, Barry, this is fantastic. Yeah, thank you for coming. I mean, it's we've had a lot of fun with this thing. I mean, you've been one of the most fun guys in the hospital that I've ever even experienced.
Really,
so.
I just wondered what that's all about. I think you're right. I do chat people up.
Oh, you chat people up.
Oh, I'm telling you, it's part of maybe the most enjoyable part of being an anesthesiologist is, I think healthcare selects for people that they care about other people and they go into debt and they, sacrifice 10 years of their lives, to kind of get to the point where you can do the kind of things that we do. And I think they're wonderful people. I think the bar to get in there makes it just a very enjoyable work environment.
Other people have echoed that same thing. We had, Brian Wisenant was on, and he talked about one of the most satisfying things about his job is, you're helping patients and all those things, but it's also the team that you're working with that make it so
I've had,
enjoyable.
In addition to being an anesthesiologist, I used to be an internist. And on an internal medicine team, you're on a team. And in anesthesia, I mean, I really have no idea what my partners do because you're a solitary actor, and you just have to find your way into whatever room, whatever's going on in the room. And one of the things that's fun is that you're in a different room every day. There's almost always somebody new that's in there. So socially, it's just a very wonderful environment.
And you're the last person that gets to see that patient awake.
Yeah.
Which is super cool.
I think you do a great job as well of integrating the entire room with everything you're doing, the way you communicate, the way you bring people in. I think it's super uplifting. It's fun to be around. And that's one of the things I've always viewed from afar with you is how well you do with everybody in the room.
Well, thank you. I think it's interesting that I was trying to think over like the last 25 years, like which one of you guys I've done more cases with. And, you do different things. And, in fact, on this podcast, who's the target audience? Like who watches this?
Well,
that's a great question.
It is a good question. A lot of other device people watch it, like my colleagues, his colleagues. A lot of customers watch it, like people that that are cardiologists, electrophysiologists, surgeons. We've had surgeons on as guests.
I heard one. I did a little research here. I listened to 3 podcasts.
Listen to this.
Yep, he's a friend of the pod.
You're a friend of the podcast.
I mean, he's a burgeoning friend of the pod.
We got to back up here a little bit because we knew he would be a great guest, but I didn't consider him as a guest until we ran into each other at Whole Foods.
Right.
Oh, really?
And I hadn't
Hi, Brent. How are you, man?
What's
for dinner?
Barry for a while because you stopped doing TAVRs.
Yeah.
And so, like, my interaction with you kind of went by the wayside.
Right.
But then I saw you at Whole Foods.
But we're still friendly in the hospital. I'm still there.
No, we still high-five.
I'm just an old man. Sadly.
We're all getting there, buddy.
I know. I was happy when I run into you. I thought you were retired, but you're still doing some stuff at the hospital.
Right. Procedural sedation now. But,
yeah.
I did the challenging stuff for years. And you get to be over 60, and I think it becomes a young man's job at that point. And our group has a way of kind of easing you into retirement. So I've gotten to experience a little bit of retirement, and with a little bit of work now and then. So I get back in the hospital and I get all the social things.
That's for someone like you. That's probably a big part of what you've already mentioned it, enjoyed about your job.
Yeah.
Is the social interaction, and so I think,
every patient is different.
Yeah,
and you just sort of adapt yourself. I come on kind of strong, and then I back off quickly if they look like that's not what they need, right? So it mostly works out.
That sounds about right.
You can't be the greatest match for everyone. So I just start out being me, and if I need to be less me, I can
be a little less you.
Then there's Versed and fentanyl. We can
right.
Yeah, you were my. I think you handled my a couple of my aunts' anesthesia, and you were one of the things they remembered about their whole experience.
Well, that's nice.
I didn't say it was good, Barry. I just said
you were memorable.
Ouch. So back to you guys. So the people that watch
I knew this would happen.
I was wondering,
of course. We're interviewing Barry, and he's like, "Well, back to you guys. This is what we love about him."
I like this. So, and one of the people that we're kind of after is people that don't know anything about this industry. I mean, the medical device industry is kind of an enigma, and whenever we've talked about playing golf, people are like, you do what now? You're where? And so just opening people's eyes.
You talk about that on the podcast.
We have.
Yeah, because I'm thinking, everybody like looks at their background and it always leads up to their amazing career, so to be like, my father beat me, but it taught me, how to put up with a bully,
persevere,
and that helps you to get through a surgery residency, something like that.
Yeah.
I mean, we're really lucky in Utah that you're not supposed to be like that. And I looked at people from early on in training, and people are so wonderfully nice in Utah, and we have just where we operated at Intermountain Medical Center, we have just the most lovely surgeons.
This is true.
It's true. And so your training was at Yale, and then you were in California, correct, as well?
Yeah. So I did. I'm from the South Jersey side of Philadelphia, and so I grew up there. And I really came of age in the 1970s is really when I started thinking about what I wanted to do with my life. And you've seen the shirts where the people go, I may be old, but at least I got to see all the great old bands, So I saw Led Zeppelin 3 times, and
of course you did.
the Stones, and I saw Queen for the first time in a movie theater.
Nice.
They had one album out, and they just raised up the screen, and there was, Freddie Mercury and the rest of them just, you knew you were in the presence of greatness.
Right.
So I really don't have I've listened to some of your other people, and like the NFL guy. I don't
Jed
know,
DeVries.
you may have had
Yeah.
more. I just dropped in after seeing you in the store, and I thought, oh, that sounds interesting. Because I know you guys, and I think how do you do a podcast? Are you in somebody's basement? And how do you establish a presence in this amazing world of podcasts that has just exploded? I mean, I probably listened to 1,000 hours of podcasts since I became aware of it. It's really educational and entertaining. And, you guys talk about sports, and I don't know anything about sports. I mean, I suck at golf, and yes, I played Pebble Beach, but they're, I'm just... I'm the worst guy out there, but I'm pleased in general. People are pretty nice to me.
Yeah.
So but I don't have that background. I don't have the military background, and that my drill sergeant, showed me, how to do my job. But anyway, so the 70s, I was thinking, how different cardiology was, and I always kind of thought, when I decided to go to medical school, that I would be a cardiologist. But after my medicine residency, I realized I really don't like clinic. And part of that may be, unless you're a specialist, like if you have some interesting disease, those patients are all whisked out of primary care.
For sure.
And even if you make some incredible diagnosis like, oh, you have polymyalgia rheumatica, and you start them on some medicine, they're gone. They never come back. And, so you're left with people that, they have a couple of key chief complaints. And they're things like, can you fill out these forms so I don't have to work? Or can you refill my narcotics? Or, I have headaches. And there are things that, like with headaches, they could be having a bleed from an AV malformation or something really serious, and you've got 12 minutes to figure it out. So I just thought, God, and you're not allowed to order any tests. So the opposite of that is our world, where every test that you possibly need before you implant a $30,000 valve, right, has been done. So you have all these questions answered.
Yeah.
And it makes practicing with all that information just much more gratifying than swimming around in, oh my gosh.
So talk about, you were an internist.
Right.
And then you decided, that's not for me.
Right.
And then you went back and did an anesthesiology fellowship.
Yeah, right. So I did both of those. So I did the anesthesia residency at UCSF. Interestingly, that's where Brian Wisenant went.
Right.
And Kent Jones. We were all doing a case once, and we realized, oh my God, we know people, from UCSF. The change in what's happened over my career has just been absolutely amazing.
So when you finished, was this your first job in Utah?
That was my
only
question
job.
too. Yeah,
It's my only job.
Your only job.
Right.
So what year did you come back?
Let's say 93. I might be off by a year, but something like that.
And you started at
early
LDS
90s.
Hospital?
Right.
Yeah.
So the surgeons there were like John Doty.
No, John wasn't there yet. So Don Doty was there.
Don Doty. Don Doty, yeah.
So Don Doty was there. And, when I landed, the new things to do were minimally invasive cardiac surgery, and the system was called HeartPort, and Steve Clayson was instrumental in that. And Kent Jones, of course, he's always right in there innovating, right, for all the years. So he was involved in that too. And, we were trying to do surgery, full open heart surgery through small little thoracotomy incisions. And they would do that with a series of catheters that I was supposed to put in. It felt like they were just transferring all the risk to me personally.
Really?
And I thought, is this what I signed up for? Because this is nothing like my anesthesia residency or my fellowship. And I did a fellowship in transesophageal echo. And then came out here, and that was absolutely necessary for this minimally invasive kind of aborted process because the outcomes weren't acceptable.
Outcomes back then they weren't what they are today. I remember I was talking to Ed Miner not long ago about some new data that we have in the TAVR space about treating patients early, really early, as soon as they have the disease, whether they're symptomatic or not, because they do better if they get treated.
When you say treat them for what? Aortic sclerosis?
Stenosis.
Sclerosis here? Oh, I think I saw a slight,
Slight narrowing?
Yeah,
No,
this is a device guy, right? How do you guys get paid, by the way? Do you guys?
Are we going to go there?
Is it on a volume thing? Because I have never seen anything like that, from... I think when I was in medical school, there was some statistic like the medical industrial complex.
Yeah.
Exactly. Spends $8,000 per doctor per year to guide them into using whatever their system is. And I thought, they made that illegal just when I started, right? So no more pens, no more lunches, no more trips to places. And I thought I just can't imagine that really influencing me to use somebody's product over somebody else's. And in all the years I've seen you guys, it seems like you people are more there to help this process. Well, you don't say, oh, who's on the Edwards guy or, the Medtronic person here. I don't even know how it works, but it doesn't seem like your job is to influence us. It's to help us, do the best job we can.
I would agree with that. There is definitely a range of device rep.
There are.
Out there. There are, you could there's, say, orthopedics, where everyone has a knee, and all those knees are very similar. And you are trying to influence the doc to choose your knee.
Maybe we just don't see that in the operating room. Maybe that happens
by the time
outside of that.
Exactly. That decision's been made by the time that you're in the room where we're going to do a valve or Jason's going to do a pacemaker defibrillator. The doc's already chosen that device, and then it becomes, how do we get the best outcome for the patient?
Correct.
And we've always said, this is a theme on the show, we're always like, okay, patient first, physician second, product third.
Yep.
If you do the first two right, if you think about the patient, you think about that outcome,
Nice.
You think about making sure the physician has the resources he needs, then the product side of it takes care of itself.
Do you feel like, because if we went back to like the partner trial, the early days of that, what a wild ride that was. And it's one of these things where I would say, if I did lists of people that I think are just gods, it would be Brian Wisenant would be probably at the top of that. And the reason is, when we were starting out in that, those patients were oh my God, and we had deaths, right? And you think when was the last person who died with a TAVR? I'm sure it happens, but it happened.
Oh yeah.
In the early days, and I just thought, God, whenever you're putting in a new or doing something that's that innovative, you need somebody like Brian Wisenant who really rallies the whole team together. And I feel...
No, and he had headwinds too, right? Like
I'd heard that. And I'd hear little things behind, that, something bad happened in, the cath lab. And I thought, well, my God, we've done 4 of these.
Yeah.
And the patients are 95 years old, and they're on dialysis, and they're completely inoperable. And you need somebody who has some self-confidence and can rally the team through those early days. And another question about, device reps is how often do you feel like you're actually teaching them how to do this? Because in other areas, I've seen that where it feels like, and maybe that's just part of the job. That if it's early on, more about, vastly more about the overall experience with placing one of your devices than probably the guy who's done 1 or 0 of them.
We talk about this a lot on the
right?
the podcast.
I should watch your podcast.
Well, I mean, so yeah, it's interesting because Brian came on and talked about the early days of the partner trial, and we talk about all the time. Jason and I talk about. Jason sees how many pacemakers have you seen? How many thousands?
Thousands and thousands of them.
And this doctor has seen, he is going to do 10 this month. Right. And we see a lot of cases, and there's nothing that we haven't encountered. And sometimes you get the opportunity to help a case go smoother, and maybe even make sure that the outcome remains a good one because you were there and you were able to see something or offer some advice that comes from your experience that maybe isn't part of their experience. Is that a good way to put it?
I think so. Yeah, I think a lot of stuff with our devices and our side of it, because yours is structural. That's more, you're an expert in getting the things into place. With the pacemakers and stuff, I educate more on what my particular product, how the algorithms work, because keeping all those things straight can be difficult for any physician with multiple different vendors.
PVARP.
Well, yeah, PVARP's pretty common. Everyone, but it's good though. You got that. We tend to educate more on some of the different intricacies of ways that we can deliver therapy for a particular patient or a particular disease process. That's where we tend to be, educating the most. I mean, I think about this more as, hey, we're in here trying to apply a solution to a problem that exists in a population.
Well, another thing we don't see is after the device gets put in, I'm out of the equation, and there's follow-up, obviously, with pacemakers, and things, all sorts of troubleshooting. There are all sorts of problems here.
There can be, yeah.
Do you guys work in the middle of the night?
Jason does.
Yeah, he does not. I do. Whenever someone comes into the emergency department, we're getting a lot better about how we manage those things. But patients come in with a device, and they tend to page the rep to see what's going on. Is there anything on this device that we can learn about this patient's condition? Jason
was doing a 100-hour fast, and he was in like hour 86 of it, and he got called to an ER down in Utah County at 1 a.m. to check a device because this patient was having chest pain. But they didn't mention that the patient had CPR 2 weeks before. That's why he got the defibrillator. Maybe that could be the chest pain. You know it's not going to be the device.
Judgment call. That sounds like primary care.
It's like...
That sounds like primary care. So you had to go in.
March down there.
So let's ask Barry what he thought. What do you think they told the patient? Who do you think they were waiting for?
He probably blamed the pacemaker. That's probably what's causing your chest pain is this lead.
It's in your chest.
I think so. It emits electricity. It would figure here, let's get the rep down here and make him account for this.
Yeah. Do you think they told him they're waiting for the rep?
No.
Who knows?
I don't know.
We always
we want to know.
We always speculate on this. It's like...
Oh, I would.
You say we're waiting for the rep.
Yeah, if I were the doc,
if I'm the patient, I'm
said,
like, wait a minute. Who's this rep? Well, you guys are doctors. You're waiting for the rep?
Yeah, I could explain that.
No,
I think so. And,
I like that.
And maybe it's true.
Yeah.
I think, how'd the fast go? Did you make it all the way to the end?
No, I did not. So the next morning I called him and I was foggy. And he's like, "What is going on with you?" I'm like, "I'm pretty late into this fast." And the night before I'd already prepped my meals for the next day. And he's like, "You need to eat some food now." I got a little foggy.
Why were you fasting 100 hours? What's going on?
I don't know. I just every now I do it once a quarter, kind of just to go push yourself a little bit. 100's a long time. I don't like it.
Yeah, I don't.
100 hours.
Yeah, no, yeah. I don't like the idea at all of that.
And there's guys that do it differently, like with some bone broth and some different things here and there. But I don't know. That was the first time I had tried that, and that was a bit much. Yeah.
Have you had any guests that you think, oh my God, this guy sucks?
Not until now.
Were you thinking that too? Because I'm like, wait a minute.
If you could have anyone on right now, who would it be?
Barry Berquist.
We're doing it right now.
I knew when I saw you at Whole Foods, I'm like, Barry is going to be a terrific guest.
Have you had an anesthesiologist before?
No, you're the first. You're breaking new ground. You're the answer to a trivia question.
Yeah.
Who was the first anesthesiologist on the Biascast? Every guest I think has been really good.
Everyone's been fun. Yeah. What's been your favorite job? Where have you liked the most? Which
definitely the cath lab. And I think, thank God, you still need anesthesia for this, because as I started out in the 90s, we were doing upwards of 1,250 pump cases a year, plus all the thoracotomies, and the cardiovascular surgeons did vascular surgery as well.
Right.
So the volume was unbelievable.
Yeah.
And those patients had to do well, otherwise you'd get bogged down in the thoracic ICU and you'd have to stop the production, which was completely unacceptable to the surgeons, let me tell you. And then things migrated towards cardiology, and there were a couple of basic milestones. But when I was in medical school, you think, what did an electrocardiologist do really? And what they did is they did EP studies so they could map abnormal electrical activity. And then what? Well, then they put you on toxic medicines, which by and large did not work, and then would study you again and see if they could induce a lethal arrhythmia. And I thought, wow, you think compared to what they do now, it's just so vastly different. The cardiac surgeons came up with, cut and sew mazes, which we started doing in the 90s. And then all the plumbing interventions that the cardiologists came up with. And that used to be we have to have the heart surgery team standing by for this in case something goes wrong. And then right around the year 2000, they just decided, we've got this. And, we can completely revascularize the heart. LAD, fine. We'll do that. If we poke a hole in a coronary artery, we'll put a covered stent over it, and they just became this swashbuckling group of guys. And I remember Kent Jones saying, we used to bail them out. That's what heart surgeons were, and now they bail us out. And it's that was just part of the migration of everything towards the cath lab. And my first, on my third day in private practice, I did an open heart surgery for a closure of a PFO. Can you imagine that?
That's crazy.
Wow.
That is just absolutely crazy. And then, we migrated towards more and more in the cath lab. And again, thank God, people need to be absolutely still at critical points, like when you deploy these things, over 2 seconds. Imagine somebody moving or coughing. And the outcomes are just obviously better. And anybody would rather, let's give it a shot, in the cath lab rather than immediately go to open heart surgery. So that's been the general transformation, and
and it's more and more. I mean, so TAVR was like the first big leap, right? Well, maybe we could say it was the mitral clips, right? We started clipping in the.
Do you vend mitral clips?
No, I don't.
Yeah,
I don't do mitral clips, but I mean,
talk about something that's impressive to watch. You've got to get both leaflets of this paper-thin valve simultaneously, right?
Yeah.
And I think it'd be so much easier if you just, okay, well, I'm going to grab it on this leaflet and then wait for the other leaflet to come into apposition with that. But all those things that Brian is turning, all the degrees of freedom he has, and I think, how did you learn how to do that? And he's so confident, and he's so nice to everyone. It's just like
it's become a really repeatable procedure. When we first were doing them, not that I do them, but they could take 2 hours. And now they take about a half hour, if that. If you get one clip on it, these guys are so good at it now.
Evolution in practice just moves things.
Yeah.
Yeah.
And it's great for patients.
I just wake them up at the end of the operation. There's no pain. There's no nausea. There's no sad story about, mass transfusion and the heart-lung machine and, all the rest of it. It's just, oh, we're done? Yeah, your heart is fixed. And it would have, taken 6 months to recover from the operation that we used to do that worked fine. But anybody would rather, just go for the modern approach. And you just think, is there any end to that? How are things going to be in another 15 years or maybe another 10 years when I need something done?
Right.
And I just think it's just been a very exciting time to be in medicine, especially with these devices.
So you've got to have an opinion on this. You said something, what did you say, 900 pumps a year you were doing?
1250 is the number I remember.
That number has got to be less than half that now.
A lot less, right? I would imagine.
So what's your opinion on, as things have gone more non-invasive and they're treated in the cath lab by a cardiologist, how are surgeons getting the reps in? How are they getting their experience? And how are we training surgeons? That's a conversation, don't you think?
Yeah, and I'm not the guy to have that conversation with.
It's an interesting question. I wonder kind of where that's coming.
I've talked to surgeons, and it's a concern. It's like, they're not getting enough reps, and certainly not a lot of aortic valves. That was their favorite procedure.
Oh, for sure. A single aortic valve replacement. It's right up on the top surface of the heart. Right. They don't need to yank anything around.
Right.
And should have the best outcome, perhaps, of all adult cardiac surgery.
Right. They love that surgery.
Right.
And now the patients, when they find out they can get a TAVR and they don't have to have open heart,
right. They of course
they can. I can see a CT scan and I can look at it and go, this is outside the range of my valve. This is not the most predictable TAVR on the planet. This guy is 65 years old. This is a surgery. I'm sure you guys have talked about surgery, and they'll say, yes, we've talked about surgery. Patient does not want surgery. And so you've got all these experts trying to tell the patient their best chance for a pristine outcome is to have the surgery. You have the rep saying your best chance for a great outcome, a predictable outcome is with the surgery, and yet patients, they just don't understand. And I think it's a big challenge for these guys to help the patients understand, like, what's in their best interest. It definitely is a conversation right now. But surgeons they're getting less reps. The patients they are getting are sicker.
And when you say reps, you're being like a sports guy. Repetitions.
Exactly. I was going to say that to you because we're talking reps. We're talking your repetitions. But one thing that I've noticed too in the past, 5-6 years, we're doing more procedures like pacemakers and defibrillators that used to be just local anesthesia. We're doing them more with general anesthesia and having you guys involved. How are the outcomes changing in that? Do you feel like it's in a trend in the right direction for things going better for the patient?
Well, I think it's just the thing driving that, in my opinion, is just the expectation of patients to not experience any discomfort during a procedure. And it's a low-risk, extraordinarily low-risk anesthetic to put a pacemaker in. So I just consider it like what a great case that is, that somebody, when I was doing that, that's, I think it really is what's driving that. I mean, when we're doing a transesophageal echo on people, I'll say to them, we used to be able to do this by just squirting a little lidocaine in the back of your throat and then muscle the probe down. And I said, the problem with that is that nobody likes that.
Oh, God.
And the patient's coughing and moving around. You get a better study, you're happier, and it's just incredibly low risk. You know, I mean, we've had a death on CPRU during a transesophageal echo, so it's not no risk. But in general, the issue is if you have a problem, you just pull the probe out and we'll mask the patient until they're recovered from that. So it should be, it is an extremely low risk thing. You know, but I always wonder how much money is added on to the cost of all these procedures that people used to just be muscled through. And I'm sure it's a lot, you know, and I hope that there's a safety improvement, but I kind of doubt it. Honestly,
that's kind of what I wondered. I wonder about transparency. I always think about transparency. Like if you asked a patient and said, "Hey, listen, this procedure is you're going to be totally out. You're not going to feel a thing. It's going to be more expensive, or you can suffer through a few parts. Which way do you want to go?"
Well, I think it all comes down to that what the money thing is, because honestly, if you had to think, look at your whole life. Every dollar that you make and say, okay, what if I had to pay for something? And you could say, well, house, you know, I live in a house. I could live in a slightly less nice house, a Christmas present for your mom, or, you know, the best vacation that your family ever had. I would think at the top of that apex would be not having pain when you're having surgery, or your child. I mean, can you think of anything that you'd rather save money for? So there's an incredible value to the whole concept of anesthesia. But then it gets into a marketplace situation. If you have lots of anesthesiologists, it's not going to be $275,000 so you don't have to be awake during your gallbladder operation, right? You know, it's going to be some reasonable number. So that's the whole thing. If they said we can put this pacemaker in with local and you'll definitely feel the needle. But it's going to be $17,000 to have Dr. Bergquist come in and, you know, and make it completely pain-free. People would say, you know, can Dr. Bergquist be on standby? You know, that would be the response. But it would be, you know, it's a dollar figure. The problem now is, you know, it's not like Canada. You know, it's that number is completely opaque. And like my brother, he had to have a hernia operation, and he didn't have healthcare insurance, and he goes to the hospital, and the anesthesiologist says, I need $1,200 in cash right now. And he said, is that what you make for doing a hernia? And I go, no. You know, it's more like $200, you know, something, because it's a very quick operation. And even that seems preposterous to me, right? Right, you know, but it's if that number is sufficiently high and it's possible not to have anesthesia, you know, a lot more people would opt for that. And I don't think we have a system in place right now to, you know, make that patient have that calculation.
No,
they have the illusion that it's all free, and now this is what I've been paying for. And I think, you know, I get where that comes from. I look back over 25 years of paying to Select Health, and, you know, sometimes many thousands of dollars a month, and only 1 year did I ever hit my out-of-pocket maximum.
Right.
So I feel like I paid, except for that year, for every dollar of health care that my family got. Plus, I added it all up, over $300,000 into the insurance coffer. So now you think, oh, now I need an operation? And there are like people, there are gatekeepers out there that are saying, no, you know, you can't have anesthesia with your pacemaker. We can just put that in with local. And I think, you know, I could probably muscle my way through that problem, but an average patient could not.
Right. No, the word you use is opaque. You know, I'm a smart guy. I'm in a hospital every day. I have had a hernia operation. You get that bill, it doesn't make any sense. And then
isn't that what?
And then you get one from the anesthesia provider, and then you get the
from
one
the pharmacy,
from the pharmacy and
the per minute charge in the operating room.
It's very frustrating. But to your point, like you can look at what you pay in health insurance every week or every month, and it's a lot of money. And then yet you still have this big deductible, and you still get that bill from the from your provider,
right.
and it's really hard to make sense of it all. I think that's probably one of the biggest problems, in my opinion, that we have with our healthcare system is there's just not any transparency.
It's the lack of transparency. Read the book, The Price We Pay. It's by Marty Macari. It's a really, really interesting book on looking at our healthcare system and the way the money flows. It's interesting. Yeah,
I've found getting on Medicare. I thought, I've been paying into this, for 40 years or so. And I thought, well, when I retire, then the federal government will take care of me. And I have found, no. It's just like any other insurance company. Their job is to not pay. And their justification for that, of course, is it lowers the premiums for everyone. And I am not buying it, I think, But all of us benefit. I mean, every dollar I've made in my professional career has come on the backs of the system, have come out of this.
Right.
And so I'm not lily white or pure here, and I don't really have a better idea. I think there are other industrialized countries that have figured it out, but there's things that we do in America that are just off the charts better. And one of those things is cancer care. And I bet another thing is certainly trauma care and innovative things like you guys are doing, and that costs money. And it's just hard to, maybe that $300,000 I put into the healthcare system, I'll get that all back. Or maybe my children will get that all back.
Right.
I mean, it's just
I don't think it's a zero-sum game in insurance. And I mean, I really feel like the best thing that we can do as probably lower utilizers of the system is start to talk about prevention and really educating on prevention and being an example for people to just, start really taking better care of yourselves, because the cost in the end, it's a big savings, right? And I think we have so much innovation here because we have quite a bit of abundance, and we've created ourselves a lot of problems. We've come up with a lot of good fixes.
You talk about the outcome. It's later on in life. Most people are going to get to 60, I'm sure. And you're interested in that last 10 years of life of kind of maximizing that quality. And that seems to be the buzz now of what sort of designer healthcare is. And I don't know where we are with that, but I'm sure lots of smart people are trying to think, like, what actually can you do when you're 60 in terms of obviously sleep and exercise and keeping social interactions going especially after you retire.
Right.
Right. I think about that a lot. So I'm sure those three things are what we now think are true pillars of, enhancing outcomes in the last 10 years of your life, whatever that is. Device guys, who's listening right now? I mean, how do you say, like, oh, this was a great episode, or like, how many episodes have you had?
You are our 15th? You're our 15th?
15th.
We don't know.
We don't know if we're any good. We don't know if we're any good. We just are getting feedback that people like to listen to us, and we're trying to figure out if we've got legs in this at all.
Yeah, I mean, how do you figure out, like, how many people are listening?
Well, Diego and the analytics team back here, they can see all of it for us. So they do a good job.
They give us a little, we're getting some traction.
Good.
On Device Guys.
I'm 15.
You're 15.
You're number 15.
So I've been on with an NFL guy.
Yeah, you've been on. Well, I mean, you're in good company. Like, you're one of the first.
Good. No, I'm loving it. Ed Miner.
Ed Miner has been on. Dave Affleck.
Yeah.
surgeon over at St. Mark's, Sarah Pereira.
Sarah, that's the one I listened to.
Oh, yeah.
Wasn't she
Yeah.
great? She's interesting.
Yeah, I
Breaking
just think of-
barriers.
right.
Yeah.
Yeah, I feel like I did, one of the luckiest things in my life is when I was applying to medical school, interviewing all over the place, they'd come in, can I stand up?
Yeah.
And they go, oh my God, a white guy. That's just what we're looking for, right? I mean, there was no,
Right.
I didn't really have to, distinguish myself. It was like you take the MCAT and they're happy to see you, coming down. Hey, can you talk? What was the last book you read?
Oh, right.
And the questions were so ridiculously easy. And now I feel that, some of these places have like a 2% acceptance rate to medical school.
It's
And I
tougher
think,
now. It's tougher.
How in the world are
we
you
had
going to
a device-
distinguish yourself? I am so much better than those other 98 people. I mean, really.
We had a guy, Brett
insane.
Larkin, who's a orthopedic rep. He got into device because he didn't get into like 20 medical schools. Mm-hmm. And that was back, 30 years ago,
Yep.
when that's kind of what dictated his path. Ed Miner got into like 5 medical schools, but then you talk to kids today and it's hit and miss whether you get in. And it's so, like you say, so competitive. And you wonder, let's talk about this. We hadn't planned on talking about it, but what do you think about AI? Like if you're going to go and be a family practice doc where you are, like you mentioned earlier, just referring. I've talked to people that are involved in some AI companies that say proceduralists are always going to have a job, but maybe not the family practice, the PCP, the internist. That's
what they say. And so far, I've certainly seen that. Have you tried to get a primary care doctor?
It's hard.
It's difficult.
It's super difficult. And I think I can't get one. And I think you have one and they're moving around. I have a better practice opportunity. But in general, I think primary care is being moved almost whole scale to mid-levels.
Yeah.
And I've certainly seen that. You go see a urologist and all of a sudden you're seeing the PA. And in my experience, it's been better because they seem less rushed. Mm-hmm. They're not trying to get to the operating room. There aren't any emergencies that they're dealing with. And they seem much more relaxed and will spend any amount of time talking to you. And I feel like, wow. And they know what they're talking about because this is what they do. When I was a clinic doc, I was trained in organ system failure, and all of that is filtered out by the subspecialists and the ER. So you're left with things that it's really hard to sink your teeth into from a medical treatment standpoint, especially if you're not able to order tests. You've got people looking down on you. Dr. Berquist, you ordered 2.7 chest x-rays last month, and the average in our clinic is 2.4. Right. And I would say, does that make me a better doctor than the other people? And they're saying, no, all that we're saying is that your year-end supplement is based on you being right in the average and all these different, so it's really a hard job. So primary care, I think, for whatever reason, is migrating away from doctors. And I don't know what AI has to do with that, but there's certainly a number of specialties that are already being subsumed by that. I think most scans are already overread by AI, and a radiologist comes in with that diagnosis already. And that sort of makes sense because it works.
It works.
It works. And, these algorithms can see, 40,000 shades of gray.
And we're doing that with Echo.
And can cross-reference with, 7 million scans
huge
that look
database.
just like this and, come up with an output that is probably better. And what's the Echo program? It's called, I just saw an article in the Journal of the American Medical Association.
There's one called Ignite that I'm familiar with that ties into your EMR and your
Do we have that in our system?
Not at this point, but I have hospitals that have it, and
the question I have about that is so much about echo is in generating the images. So it's exactly like a procedure. It's not like something where you strap some kind of grid onto somebody and then it generates these amazing images. There's so much skill to doing that, whether it's the tech or the cardiologist. And
yeah, there's definitely nuance in the acquisition for sure.
Right. So I could see after you have these perfect images, you even though it's so dynamic, echo as opposed to a static slice like an MRI or a CT scan, something that things are moving around. It's very impressive that the algorithms for echo are as good as they apparently are. I haven't read any. I've just read the one paper.
Right.
And the accuracy was stunning. I thought, like, really? Because I had just talked to my girlfriend, and she said, well, that's it's going to take over radiology. I go, but not echo. Echo's too dynamic and
there's AI programs that help with acquisition that can like direct somebody holding the probe. And it can look at the image and say exactly what you need to do. You need to rotate it this far.
Really?
Yes. So there's that aspect of it that helps with acquisition. There's interpretation. So now once you have the images, are they getting read right? And then once they are read correctly, are they getting flagged? It's a critical finding if you have severe AS. Europe just changed their guidelines to call it a life-threatening finding, and it marries the echo report to the EMR, and it alerts people. Like if you're lucky enough to get an echo and you have severe aortic stenosis, there is no reason you shouldn't be treated or referred. But yet we see all the time patients that have a severe value that never get an appointment with a cardiologist. And that's what I think. That's what AI is going to help with.
Why would that happen?
It's ordered by
because the referring doctor doesn't understand.
It happens all the time. You would be surprised.
Wow.
It's ordered by
yeah, I guess it's not that surprising. I just think we operate at the other end.
Yeah. Where everyone you see has already been vetted.
Been all labeled, and they just show up, and I meet them outside.
Yeah, you never see a patient in street clothes.
Right. No, it's another great aspect of my job. I mean, I wish sometimes I had more time to kibitz with them. You started out this by saying my turnovers take longer, and I'm sure that is true. I'm absolutely sure
we had
is
a TAVR
true.
day that was like 4 TAVRs back in the early days when that was the long day.
Yeah, I remember that was
early
long,
days.
Sure.
And it was you on anesthesiology. I knew a couple things. I knew it was going to be fun. We're going to have lots of fun conversations. But I knew that, pack a lunch. Because, Barry is going to
I haven't been fired.
No,
I got all the way to retirement here. I must be adding some value.
Everyone loves you in there.
Exactly.
They love you in there.
Some people say, well, as an anesthesiologist, it really matters what your patient thinks. And I say, no, actually not. My job is to impress the surgeon, because I really think at the end of the day that person, in the 80s or 90s, they came up with this idea in heart surgery that there are 3 co-equal people in the operating room. It's the perfusionist, the anesthesiologist, and the surgeon. And I thought, no, it isn't like that at all. The surgeon's the chief, or the cardiologist in our case now. And everybody else's job is to find out what they can do to help that surgeon. And some of it's social. I just feel like there's, do you ever think like, oh, this anesthesiologist is so much better than that anesthesiologist? Seems like it's a social difference. I don't know. That's a question. Do you see a guy, because I'm thinking, what do you do with that? I think for me, there's a speed component that some people have, and sure. I'm not that guy, and the speed guys may be better, they may not be better,
right?
But the goal overall, the cardiologist or the surgeon sees the whole package. and they can eliminate your career. Just,
Well,
so there's always that review. And, I think when I was in preschool, for example, that we used to have there was a talk that I would give, and it was on
preschool.
Preschool,
Yeah.
Because people, like, if your child who's in preschool needs surgery, everybody's like, what I care about most is anesthesia, because nobody's going to die from having a tube put in their ear unless it's an anesthesia thing, and it's the greatest responsibility in I think of all of medicine is anesthetizing a child who's having a trivial procedure like that. And you just think, if you lose somebody, I mean, I don't know many people that have that kind of a job where there's zero tolerance for that kind of outcome. And just the thought of having to go look a mother in the face. Can you imagine?
No.
Oh, look, whoa, you're already done? And Dr. Bergquist and the surgeon, as far behind as possible as, coming out to explain that your child is gone. And I said, the whole thing, you guys cannot, this is in preschool, select your anesthesiologist. You don't know anything about it. You just have to trust that your surgeon is on top of that. So again, it comes down to the system, and you have to have faith in it.
Yeah.
And I don't think there's any way around that. Yes, you'd like to have the very best anesthesiologist, but you're never going to find out who that person is, and they may not even work with your surgeon. So I don't know. I guess I asked you this. Did you think you've seen a bunch of different anesthesiologists, so there's speed that could be a difference.
Right.
Do you feel like there are other aspects other than I'm funny, or I chat up everyone in the room?
I know. I think the affability is a big thing, right?
Sure.
Like, can you work with people? Do people like working with you? And I think that's a big thing. But yeah, I have seen. I've seen. I won't mention sites. I won't mention.
Right.
But,
no, I'm not asking.
But there's definitely there's some folks that have issues. I'm thinking of one guy that's, you can go like 5 years without seeing a patient aspirate, but I've seen one guy have 2 aspirations, and so you wonder what's going on there. But yeah, I think there's definitely a range in your experience. And what do you think?
I think the anesthesiologists contribute mostly to the flow of the room and the flow of the day. I mean, as you have patients coming in comfortably and coming in and out, I think the drive of the room is a lot based on how you guys handle the situation and drive everyone in that procedure that I think is really, really effective. Or it can be the other way. And I think it's a matter of how you approach those people, which is where I think one of your strengths really lies.
I got a good anesthesia story. You want to hear it?
Yeah.
Okay, so I had hernia surgery. Jason knows this story.
Mm-hmm.
So I had hernia surgery, and
oh my God, you have like cups which have your device guys thing on that.
Look at that.
Okay, that's good.
That's a sticker.
What
we can
there,
modify it.
That's a sticker. I can.
What's in there?
This is coffee.
Okay, good.
All
right, go on. Hernia.
So long story short,
that's one of the most challenging operations in all of medicine.
Are you being funny?
Yeah. Okay, now carry on.
Yeah,
go on.
So I wake up in the PACU, and I look, and there's the nurse that took me in. Her name was Angie, and I said, "Hey, Angie," and she got this look on her face, like relief. And that's kind of weird, a weird reaction. And so I start looking around, and over at the desk, there's like 12 people. And then I see this kind of disheveled, and I knew right away what had happened. And I asked her, I'm like, did I just get CPR? And she goes,
are you serious?
Yes.
Oh, I'm sorry for mocking your CPR event.
It's okay.
So
Barry.
what happened?
I'm
when were you going to tell? You never told me this before.
Well, so this
how much time have we spent together?
This is a great story. So this is 2019. So they call a code. And my
God.
wife is in the waiting room, and they show that there's only one patient in the PACU, and she knows that it's me. Then they call a code blue in the PACU, so she's freaking out. She actually called Jason.
She did.
And
Was this at my facility?
no, it was not.
Okay.
This was at a smaller facility. So anyway, I ended up being fine. They kept me overnight for observation. I they were trying to bag me, and so I had some jaw pain and I had some chest pain from the compressions, but I was okay, right? And
Okay, Stack, what happened?
well, so let's fast forward to my next operation. I had rotator cuff surgery. Heather comes with me, and she wants to make sure everybody knows what happened to me.
Of course
right?
she does.
So
Sure, fair enough.
everybody in that, like the parking lot attendant knew that I got CPR after a hernia operation. So the anesthesiologist comes in to visit with me before my operation, and he reviewed the chart. And he said, they told me I had laryngospasm. That's what they said happened. And he goes, I don't think you had laryngospasm. He goes, I just looked at your chart. You got a big dose of narcotic for whatever reason right before the end, and then you just stopped breathing. And he was buttoned up. He was just like, I'm not worried about this one bit. But
Is something awful going to happen with your rotator cuff?
No, it went great.
Oh, good.
It went great.
Good.
But
I
he was convinced that it was an anesthesia
Oh, wow.
problem.
Yeah.
Like why would I get all that narcotic? And then, thank God the PACU nurse had noticed.
So that was all in the PACU.
It was all in the PACU. Yeah.
Wow.
But yeah, that's
anesthesia.
And you don't
anesthesia
know.
can be
Like
kind
you
of
show
a
up
scary thing.
Yeah, you show up that day and you get who you get.
Yeah.
But here's kind of the funny thing about this story is we talked about Brian Wisenant, and he called me. I think I got home on Sunday. They kept me. I got home on Saturday.
From the rotator cuff, or
no? This is from after the CPR, and so he calls me and he goes, "Hey, how you doing?"
Real chest compressions.
Real chest compressions.
You
and
don't do that for laryngospasm,
Not
right?
usually.
Typically, there's more. Yeah. Okay.
So Brian goes, how did it go? And I'm like, it went okay. I said, weird thing is I ended up getting some CPR because I stopped breathing and da-da-da. And he's like, you got to be kidding me. And he's like, are you okay? He's like, they kept me overnight. But anyway, I'm okay. And he goes, okay, well, anyway, I just uploaded a CT scan for you.
Take a look at that.
Are you available tonight?
Can you take a look at that real quick?
peek
We're
at
trying to
that.
decide what we're going to do with this patient. If I bring that up with Brian, he will deny it, but it's true.
Of course, they'll deny it.
I was going to ask you about running into you at acoustic music and your guitar playing.
Oh,
But
what do you play, Barry?
I don't want to talk about that. So
Next question.
no. I play all sorts of things. I would say I was in a band that started in 1968, and we had our 50th anniversary concert in 2018. And so we're still somewhat active. But I play things that the main guitarist of the band wants to play because we're sailors. And when I say we're sailors, I mean he's a sailor, and I'm not even a crew member. I'm what's called a passenger. But
You just carry a life jacket?
yeah, something like that. But we go sailing, these amazing sailing trips at least once a year, and take guitars, and that's
do
essentially
you
what
like
I'm
Jimmy
practicing
Buffett?
for.
Is that the type of music you play?
No.
What do you
No,
play?
but I like Jimmy Buffett. I don't play any of his music, but I'm sad that he's gone.
Yeah, me too.
Yeah, me too.
So Bob Jarvik, would you like to have him on your? Oh, he's gone too.
He's gone, but he has,
my. Bob Jarvik.
I think we got to have Barry back on. I think there's still a lot of meat on this bone.
Yeah, I agree.
Okay.
Thank you for coming on.
Yeah.
Device guys, thanks for having me.
We'll get you a sticker.
Brent.
We're going to get you a sticker, Barry.
Oh, that?
Yeah. You can put that on your fridge or whatever. And
So one thing I just wanted to say, Jason, over the years, I've been very impressed with the veins that you have.
Oh. Jeez.
Yeah.
No, yeah. I mean, that's what I look for in a human is IV access.
IV
Yeah.
access.
IV
Yeah,
access,
I've been
yeah.
told that,
You're
you know,
looking good
if
here.
I fall down, and cut myself, it's all over. I'm
Right,
bleeding out.
right.
Yeah, that's
Bleeding out. But well, thank you so much for coming. This has been great.
Okay, well, thanks for having me.
You bet.
And everybody, thanks for tuning in. We owe you a huge debt of gratitude for watching Device Guys. You know, we did talk to Diego earlier today, and maybe we ought to get out a little more Instagram presence. And so, you know, you can find us at Device Guys on Instagram. And if you think you'd be a good guest, or you know somebody that would be a good guest, or you have a good topic
Want to just
for
come
the
on
show,
and shoot back and forth with us?
what do they do? Do they slide into our DMs?
I don't know how that works. But
Zach,
just
what do you do?
Shoot
Do you
us,
slide?
shoot us a DM, a direct message.
I don't think
believe.
you shoot. I think you slide.
Do you slide?
It's a slide. You slide in the DMs. Hit us up on the gram.
Let's do
on
it.
Device Guys, and maybe we start a little dialogue there. And we're getting a little momentum. Thanks for watching, everybody. We appreciate it.
Yes, sir. And I tell you what, you're out there. You see someone out there without a smile on your face, give them one of yours, just like Barry.
Just like Barry.